Welcome to the Oxford University Psychiatry podcast series. My name is Daniel Morn and I've got Professor Phil Cowan here with me today. Thank you for coming, Phil.
Thanks for the invitation, Daniel.
It's really good to have you because you've done some really interesting work over the past, several years really.
Very many years.
In psychopharmacology. And your particular area of interest is in antidepressant medication.
Yes, basically the treatment of mood disorders, particularly depression that doesn't respond well to other treatments.
Okay, and could you just begin by telling us what your main areas of interest are in that field?
I suppose it's trying to understand how the medicines might work, trying to understand what the underlying pathophysiology is of the condition, why some depressed people don't seem to recover as well as one would like, and then trying to come up with new treatments, mainly pharmacological in my particular case, that might be helpful in patients with that kind of problem.
When you talk about depression, do you see it as a unified entity, or do you see depression as an umbrella diagnosis of which there are sort of many conditions within that?
I think it must be like that it's a common condition, the features are fairly variable, and I suppose when you're a psychiatrist you tend to work in one particular area, so people who have quite severe depression, quite disabled by it, and not doing well with first-line treatment. So you have that particular group in mind when you work as a psychiatrist.
So you're working at the more severe end of the spectrum compared to perhaps what most people might have encountered in their daily life with people they know who might have been depressed. You're thinking that the people that you see are perhaps more functionally impaired, or does it look different? Is the character or nature of the condition particularly different? Is there something you look at, or?
I think that's right, Daniel, because depression is very common and often treated very successfully in primary care, and so people would respond to psychological treatments, maybe first-line antidepressant medication if that was necessary. So I'd say that the people that I would see, and most psychiatrists, the depression would be unremitting, and that's a feature which causes a lot of distress for the patients, because if you're depressed you often feel things aren't going to improve, and this is confirmation of it. So it's severe, it's long-standing, and it seems very hard to shift. Certainly true, as you said, in those circumstances it can be functionally disabling. So people who are often very capable, very accomplished, find that they can't work properly, and their personal lives are extremely disrupted.
We've had antidepressants for over 50 years now as psychiatrists. We've been using them effectively in many cases. Where's the frontline advancing area in antidepressant research at the moment?
I think the main advances in my professional career have been the fact that more antidepressants are available and they're safer and better tolerated, but by themselves they're not necessarily more effective than the older ones. So the failure to make more effective treatments has been a disappointment. On the other hand, because more drugs are available, you can usually find something that suits an individual. Moreover, it gives a chance for treatment combinations, and some patients with resistant depression seem to respond to that approach. So I think practically we're doing better, but individually we haven't really got a drug that's made a huge difference in terms of effectiveness.
You've done some work into the effect of ketamine on people with depression. I was wondering whether you could tell us a bit about that.
Yes, that's an interesting development, and it started from observations made in the United States that intravenous ketamine, which is a widely used anaesthetic and has been used as a model for various psychiatric disorders, when given to patients with acute depression, made them feel much better, essentially back to normal, about an hour or two after the infusion of a sub-anaesthetic dose. Particularly intriguingly, in about half the patients, that effect persisted for a few days. So it was a striking effect because normally antidepressants take a long time to work, several weeks. They don't work that fast, therefore. And though one can imagine treatments that work quickly, for example, sleep deprivation is sometimes used in that way, it's unusual for a quick-acting effect to be sustained. Further, ketamine pharmacologically works in a very different way from our standard antidepressant treatment. It blocks a kind of glutamate receptor, so it's another neurotransmitter from the ones we normally think about in terms of antidepressant action. And therefore, it may provide clues to a whole new class of antidepressants, which, as I was saying, we badly need to improve on what we're doing at the moment.
That's really interesting. And have you seen any? Have there been any evidence suggesting that ketamine is potentially an effective antidepressant or has an effect that lasts longer than a few days?
People have tried various ways to extend the effect. So they've tried giving courses of treatment, and they've tried using orally administered glutamate-like drugs in the hope of extending the effect of ketamine. My own experience is, thus far, that's not been as successful as one would like. And so one's left with a tantalising position that you can get people out of severe depression for a few days or a week, but you're not confident you'll be able to sustain it, and that's a major problem.
Thank you. And you've touched on an issue in depression as a psychiatrist, which is that we have lots of drugs at our disposal now that we can use to help patients with their depression, but often there's not much difference in the efficacy or the effectiveness of that medication. There's often quite different side effect profiles.
Yes.
Is there anything you could advise people who are beginning, or psychiatrists who are beginning treatment of somebody with depression? Are there any particular class of drugs that you would suggest to begin with, and what's your standard sort of approach?
Well, I think for most of us now, the early stages of treatment are set by guidelines. So if you read something like the NICE guidelines, it'll tell you what circumstances to think about medication and then what you might use first line. And so that's tackled very competently by GPs usually. For psychiatrists, as I said, you're a bit further down the line. People often tried a psychological treatment, perhaps a couple of the standard first-line antidepressants, such as the SSRIs, fluoxetine, drugs like that. And so we're then left in that position, wondering what to do next. And I think you'd have to say that the treatment guidelines tend to be based on trials, evidence, and there's not a lot of evidence about next step treatments. So this is where your clinical experience and your knowledge of the patient becomes absolutely paramount.
And what is it about the patient that helps you? What kind of things do you look for in a patient that helps you make those clinical decisions?
I think there are a number of aspects. Obviously, in any psychiatric consultation, one of the fascinating things is that you have to live in a sort of first-person world, trying to access the experience of the individual, and also somehow synthesize that or fuse that with a third-person scientific notion of what's going on, perhaps, at a neurochemical, neuropsychological level. And that's one of the challenges, one of the excitements of doing psychiatry. So the first thing is to make a good emotional connection with the patient, to really understand what their experiences are, to put this depression in the context of their life, and actually particularly helpful to get an idea of what's not right now, what would they be like if they were well, how have things gone when they were well. That way you get a notion of how much it looks like an illness that somebody should be able to make a good recovery from. Often seeing a partner or friend is very helpful in that situation. So that's the first thing, a really thorough assessment at a psychological level.
Have you done any research on this sort of level of clinical decision making, on particular drugs that happen in particular circumstances? You've done some work with agomelatine, and and things like that, would that lead you into making a decision in a particular circumstance for the patient?
Well, that's been a goal of many researchers and many research authorities to try and stratify patients, to try and work out what treatment should you give someone, because there are many different drugs with slightly different pharmacological mechanisms, and often you just have to go through things in a careful, empirical way. And that can take several weeks or months, which obviously is very disheartening for someone who's depressed anyway and is rather despairing about the future. If there was a way we could identify what to use, that would be fantastic. But at the moment, the current treatments we've got, the current investigations, brain imaging, genes, clinical characteristics, not terribly helpful in trying to predict what someone's actually going to be helped by. But that's an area where there needs to be substantial progress.
So, in a sense, we are in a position where the crucial part of clinical decision making, and a lot of the research that you've done over the years, has really pointed to the fact that we need an accurate and sort of personal engagement with the patient to really understand their situation and then to make decisions based on that.
Yeah.
There are the old-fashioned medications, tricyclic antidepressants, and the modern medications, the sort of serotonin-based medications. Do you feel, looking back, that we've? I know you said there's no benefit in effectiveness, but do you think we've come a long way since then?
I think from the point of view of treating a broader range of people with depression, we probably have. My own feeling is actually, probably because I'm fairly elderly now, that the tricyclics are still a little bit more effective, but they're hard to take and they're dangerous in overdose, so they're not easy to use. The SSRIs are effective for many patients in primary care. They're much easier to take, they're safer, and so that is a kind of useful practical advance in treatment, even though they may not be any better than the older ones in terms of effectiveness.
So we've talked a lot about the clinical aspects of how clinical decision making has changed, and in a sense we have a lot more options for treating a lot of different types of people. In what ways has the knowledge developed? We've grown rapidly in our ability to image the brain, our ability to understand all the different neurochemicals and the synaptic processes that are going on. What do you think are the real advances in knowledge about